Good evening. I'm Németh. I'm the second vice chairman of the European region, and I'm happy to see you all attending in such large numbers. I want to start by saying that this webinar will be recorded for all those who could not attend this evening. The recording will be available on the region's YouTube channel, and please keep an eye on the European region websites for updates. You are all very welcome to this first webinar hosted by the Advocacy and EU Matters Working Group. The working group is one of the 3 permanent working groups of the European region. The working group members put forward to the executive committee by the member organizations focus their work on all matters relating to advocacy on policy affecting the physiotherapy profession. Liva Tiesnese will lead this session together with Aderito Seixas, who will moderate the questions. The theme of the webinar is, as you know, self-referral and direct access to physiotherapy in primary care. Direct access from a health system point of view and self-referral to a physiotherapist from a patient's point of view are issues that are very relevant for the physiotherapy profession. Constance Schlegl will start and talk about the general understanding, the role and the competencies within primary care. Rebeca Nugent from Sweden, Chris Mercer from the UK, and Firas Mourad from Italy will present specific testimonials. And we will leave plenty of time for the audience to engage in the Q&A, as we want this session to be as interactive as possible. I trust you will enjoy this webinar, and I'm happy to hand over to Liva.
Good evening, dear colleagues. Thank you, Tim, for the introduction. I will moderate this webinar together with my colleague Aderito. We are colleagues in the working group, and it is my honor to be here and be part of this event. Well, we have gathered experts of the field to get the best impression on physiotherapy's role in primary healthcare within Europe. But before we jump into the excellent presentations, there are some technical details. We invite you to be active and put your questions in the Q&A or in the chat. Ask the questions to the speakers. If there will not
I think we have a slight communication problem. Liva, are you back? Because everything dropped.
Did everything dropped? So sorry. I hope that everyone's back.
We're introducing the Q&A. That's all.
Your Q&A. Okay, so I invite you to be active and ask the questions in the Q&A. Well, we will start our webinar with our first speaker. Our first speaker is Constance. She is a physiotherapist. She's not only the president of the Physio Austria, she's the head of the Geriatrics and Gerontology Working Group of the Austrian Society for Public Health. She is also a member of the Advocacy and EU Matters Working Group. She will introduce us with the concept of the primary care, the role of physiotherapy in primary care on various aspects, and give an overview on the necessary competences. Constance, I give the floor to you.
So thanks, Liva. Thanks, Tim, for the good introduction. Hello, everybody from Vienna, Austria. Maybe because of technical resources and system resources, it would be an idea that everybody switches off the camera to make the connection more stable. Yes, it's a bit a challenge to talk to a black screen, but I'm used to that and will try to make the best out of it. So before I start my presentation and take you into the world of primary care and primary health care, and the role and competences of physiotherapy, we would like to ask a question and to participate. We would ask you to participate in being active and responding. We would like to know who is working in primary care. Liva, may you be so kind and please put the question on the screen.
The question should be on the screen.
Yes, so you can take one of the answers.
How much time do we give to answer the question?
I would say half a minute. Can count down from 30 probably, or make 30 squats, everybody. I think you can see the answers coming in, Liva, because I cannot see it, unfortunately, but I'm really curious to see what the outcome is.
Do you see now the? Yes.
So it's quite equal, the ones who work in primary health care and the ones who work in some other field, and we have little who don't have primary health care in their country. So thank you very much. This is also very interesting for us, and I think for everybody participating too. I will share my screen now. And then we jump in the presentation. Yeah, it's all about primary care and physiotherapy today. It's about the role of physiotherapy, the competences that are required, and also which kind of advocacy within Europe is necessary to provide that primary health care or primary care, we will talk about the term soon, can be available in every country, and physiotherapists will be playing a big role and an important part in it. So we had one question first before we started, and now we're having another question first before we go into details. Primary care and primary health care, is this the same? So we know that primary care and primary health care are very similar terms. They are often employed interchangeably. They are also used to denote quite different concepts. Primary care often describes a narrower service delivered to individuals, and primary health care is a broader term. Primary health care is based on the World Health Organization's core principles, which you can see on the website of World Health Organization when you look for primary health care. It describes an approach to health policy and service provision. Primary health care includes both services, primary care services and primary health care services. And it's very public health focused. So the growing international recognition is that primary care and primary health care are two quite distinct entities, and they are often used similar. So if I speak about primary care, I also mean primary health care. And also when I talk about primary health care is meant too. We know that primary health care is the most efficient and effective way to achieve health for all, which includes that this is a very public health focused thing. Let's have a short view on public health care history. It's nothing really new, even if it's a very modern approach to healthcare. In 1978, in the last century, the principles of public health care were first outlined in the Declaration of Alma Ata. But in October 2018, 30 years later, global leaders ratified this declaration in the Declaration of Astana. And so we are still having the benefits of this declaration. So primary health care was born in 1978, and now in 2022, we are talking about the role of physiotherapy and the chances that we see in it. Primary healthcare is also a modern approach to healthcare services. It's usually patient's first point of entry. It's comprehensive, interdisciplinary, patient-centered, and community-oriented. Where can public healthcare services be found? Primary healthcare is provided in a community setting on one hand, and on the other hand, primary healthcare can also be accessed through health advice telephone helplines run by nurseries, for example. There are some public health care approaches and targets. It's about meeting people's health needs throughout their lives. It's addressing the broader determinants of health through multi-sectoral policy and action. It's about health in all policies. It is also about empowering individuals, families, and communities to take charge of their own health. And one of the big targets is to provide care in the community as well, that care is provided through the community. And so it's about asking people to participate in the system and to contribute about health. Who are the public health care providers? And where do they work? They usually work in the community within public healthcare centers and primary healthcare centers. Any healthcare professional who is the first point of contact for the health system can be a primary care provider. People usually visit their general practitioner as the first contact when they're having a health problem, except it's an emergency when they go to ambulances and also can be taken to hospitals. If it's a slight emergency, also primary healthcare centers can be the first address where they can seek and find help. There are some requirements for primary healthcare providers. It's a multidisciplinary approach, integrating different types of healthcare professionals, short HCPs, who can be physicians, nurse practitioners, pharmacists, dietitians, social workers, and rehabilitation professionals as physiotherapists. Also required is a change in or expansion of different roles and methods of service delivery. This may be required with incorporating healthcare professionals. So there are two primary healthcare models which are most relevant for incorporating physiotherapy into primary healthcare. First, let's have a look on the integration model, where physiotherapists can be directly employed and provide services in a public healthcare organization or a center. The second one is the consultative model, which is also very popular in some countries or also regions of countries. Physiotherapists there can be also employed. They also can work in private practice and provide services outside the private healthcare organization or center. One of the big targets is that primary healthcare models should be paid by the public hand so that the patient doesn't have to pay for it. Also important are the healthcare services in primary healthcare. It's diagnosis, treatment, and care, promoting good health, preventing health problems, early intervention, and managing ongoing and long-term conditions. But it's also about advisory on managing and stopping smoking, on hazardous drinking, on stress and depression. It's advisory on poor diet and also on physical inactivity, which is sure one of the core competencies of physiotherapists. This is one reason, one of the several reasons why physiotherapy is so important in primary healthcare services. On the website of World Physiotherapy's European region, you can find a lot of information material. You can find some graphic infos like you see here on this slide. There's also a position paper about primary care. And this was done by the professional practice working group of the European region, who was formerly known as the Professional Issues Working Group. And I'm very happy that there are some members and also former members of this working group attending this webinar tonight. Hello to everybody and thanks for the good work that you've been doing on this matter before, so that I can do my webinar based on your work. Thanks a lot. And in this position paper, there's clearly said that physiotherapists are qualified to screen, diagnose, and provide appropriate treatment or referral. And this is one of the important roles and things that physiotherapists can and should do in primary care or primary health care. Which are the most common physiotherapy services in primary health care? It's work one-on-one with patients. It's to provide fall prevention training, which can be either done in a group setting or also in a one-to-one setting. It's about educating patients and caregivers about preventing and managing chronic diseases. One of the services is to prevent and to manage chronic conditions and promote health and wellness within a community in larger group programs, for example. And it's also about screening and diagnosing patients as a primary contact, which we will hear more about it on the direct access part of this webinar. Picture says more than 1,000 words, a colleague told me recently. So if we have a look on the physiotherapy roles that we can and should fulfill in primary health care, it's according to the Németh roles, which describe the roles that medical healthcare workers should have. First, let's have a look on the physiotherapy expert. Then we will have a look on the team worker or collaborator, on the communicator, the role of the manager, the role of the healthcare promoter, the role of the innovator or scholar and scientist, as it's also called, or on the professional. And these roles, everybody of us fulfills in his daily life. Most of the time, we are not aware about this because we are very well educated. And so we are able to jump from one role into the other and also combine them. And this is a very, very big advantage for our patients. And according to the roles, there are the competences. Let's talk a little about competencies before we jump to the competencies of the physiotherapy expert. What is competence? Competence is the ability and willingness to do something, but also comprises the responsibility for doing it. It's the coordinated application of diverse individual tasks. It's also dependent on the situation, available in the context of executing several tasks and demands. Competencies combine knowledge and ability and skills to the ability to act. And competencies cannot be directly observed. The competencies of physiotherapists are written down in several competency profiles, which are provided by the professional organizations in the countries. And it's really useful to have a look on them. So the physiotherapy expert with his special competencies in primary health care, it's to identify ways to review hypotheses in an efficient way and to differentiate them according to economic points of view. It's about to prioritize procedures based on how qualified and appropriate they are. It's to evaluate results from the diagnostic process against the backdrop of unstable or highly complex situations. And it's also about to evaluate interdependencies. It's to define and prioritize therapeutic aims based on biopsychosocial aspects, and also to consider unstable or high complex situations in the therapeutic setting. The team worker or collaborator should be able to develop strategies to use resources effectively for multi-professional cooperation, and also to use models of performance and to create innovative approaches for multi-professional cooperation. He should be able to manage interfaces and to promote, to establish symmetrical professional relationships. He should be actively shaping team development, and he should also be an expert on conflict management. It's important to prevent escalations of conflict in a team. Competences of a communicator. They are to process complex information and communicate this information adapted to the listener's need, who can be a patient, another healthcare professional, also a stakeholder. This can vary. It's to steer communication processes on an organizational as well as a social level. A communicator's competence is clearly to be able to conduct a dialogue on social, expert, and scientific level, to be able to participate in health political dialogue, which includes situations that involve representing the profession. A physiotherapist in primary healthcare also needs managing competencies. He or she should be able to analyze and utilize available resources according to their degree of effectiveness. To assume leadership tasks within a team is one of the competencies. To create and implement sustainable and effective procedures for a quality management system, and also to support team members when they are planning their daily work, when they're planning their professional practice, their career, and also help them to maintain a personal balance within the big approaches that they do when they are facing situations like pandemic situations that we're having it right now. Innovating things, it's also a competency. There should be the ableness to evaluate professional competences when applying the physiotherapeutic process within guidelines or standards, or to evaluate and apply quality management of professional competences, which should be practice-based evidence and evidence-based practice in primary health care. It's to apply a systematic process to gather, analyze, select, and synthesize information with the aim to evaluate practical work to generate new knowledge, and to initiate and conduct applied research projects within the context of practice. As a professional, a physiotherapist in primary health care should be able to take on responsibility for implementing ethical, moral, and legal principles, and to take over responsibility to form a better understanding of the profession within society. There clearly are a lot of health and economic benefits when physiotherapists are working in primary healthcare services. We will hear about it more later on, but there are some examples for good evidence. It's low back pain management, falls, gait abnormalities, COPD management, shoulder conditions, and also knee and hip osteoarthritis. A physiotherapist also should have healthcare promoter competences to utilize positive biopsychosocial influence factors to optimize health and well-being, to participate in health strategic development actively, to form, implement, and evaluate concepts for health promotion and prevention. There is evidence about benefits of incorporating physiotherapists in primary health care. Studies indicate that physicians and nurse practitioners valued the integration of physiotherapists into their teams, and that physiotherapy was the most requested rehabilitation service, either from other health professionals working in primary health care centers or from the patients. And the benefits of incorporating are enhanced chronic disease management, decreased wait time for consulting a physiotherapist, fewer inappropriate referrals to specialists, decreased unnecessary diagnostic testing, increased patient certification, and also cost effectiveness and increased quality of life for patients. There are also barriers of integration. And there are three kinds of it on three levels. One is the individual level barrier. It can be team members, other team members, lack of understanding about the role of a new healthcare profession as a physiotherapist coming to a primary healthcare team. And it could also be unfamiliarity with the roles of other team members, or an inadequate physician support for the healthcare professional who is new, or the perception of healthcare professionals of the professional hierarchy in the team. There are also barriers on organizational level. It can be insufficient leadership in encouraging interprofessional collaboration. That can also be insufficient time for the interprofessional team to communicate, or the lack of appropriate facilities and equipment, and challenges in acquiring physicians' patients' records. The system-level barriers identified are inadequate interprofessional education and training, resulting in lower quality and effectiveness of collaboration, and lack of appropriate evaluations to inform change. But fortunately, we also know things about the facilitators of integration, who are very necessary for becoming a full team member, an accepted team member in an existing primary healthcare team. So a physiotherapist who is new in a primary healthcare team should clearly possess leadership qualities, should be able to determine the needs and priorities of the team and patients, and be able to educate other healthcare professionals about each role that he or she can fulfill in the team, and also about the competences which we bring with us as physiotherapists. But he or she should also be possible to outline the diversity of one's role in the team. So at the end, let's talk about advocacy. What to do? It's very clear there's a broad potential impact of integrating the physiotherapist's roles into primary health care. Only little about this is known to the public or even other healthcare professionals working in public healthcare centers. So it's absolutely necessary to inform stakeholders about the potential of physiotherapy in primary healthcare or as a primary care profession with direct access. What can you do? Every physiotherapist can advocate for the profession in being active with promoting the benefits to patients, to their relatives, to other healthcare professionals on the websites or also on using social media like Facebook, Instagram, Twitter, and so on. We would be here very happy if you could help us with our work in the European region to promote and to advocate for physiotherapists' work in primary health care. And we can also provide support. If you visit our website, World Physiotherapy European Region, you can find a lot of infographics and resources, not only about primary health care, also about direct access, about autonomy and other stuff. So I'm very happy to be part of this working group and that I've been able to join you to give you some insight into primary health care within Europe and the role and the competences of physiotherapy. And I would like to thank Liva for hosting and hand over the word to her again.
Thank you, Constance, for the presentation. Thank you very much. I think we have 4 minutes for some questions, and we have one question came into the Q&A from Stavros, and he asks where it is applies that. Are we sure that the reasons are scientific and not purely to saving money in health system? I think we can share your opinion and then we can continue in the discussion part.
Well, I think you never can be sure about this. What do you think, Liva?
I have to think about it again, then I could share my opinion in the discussion part.
Mm-hmm.
But the competency framework that you shared, it is the one that you applied in Austria. Now, am I sure?
Yeah.
Okay, then I have a question about this. What was the methodology that you used to establish the framework of the competences?
In Austria?
Yes.
The method? Oh, it was done a couple of years before within one of our working groups who put together. It was done by the framework of the Universities for Applied Sciences in Austria, and they came together, and it was a long process to establish it. But it refers to the Németh rules, and you can see it on Physio Austria's website. It's physioaustria.at, and it's also available in English. And I also see a question, is it possible we can apply that in physiotherapy in mental health? I think it's about the competences, also a competency profile, probably. Yes, if I got this right.
Yes, it's about the
possible. Yes. In Austria, for example, our network on mental health is working or already done with it. I'm not sure. A colleague of mine, Nicole, is here. She knows more about it. Maybe she can put it also in the chat, the answer. But yes, it's possible. It's possible to do this on every clinic field.
I think we will continue with our speakers. Aderito.
Yes, thank you, Constance, for your insightful presentation. We are now going to have Rebeca's presentation. Rebeca is a physiotherapist with working experience in Sweden, Australia, and Solomon Islands. Since 2017, working in primary healthcare in Västra Götaland. I hope I had the name correctly, in Gothenburg. She is the chairman of the section for primary healthcare, a subsection of the Swedish Association of Physiotherapists. Please, Rebecca, go ahead and talk and give your presentation.
Thank you for the lovely introduction. Now I hope you can all hear me. So I will see if I can share my presentation here. So can you see it? So I'm here to give you a brief introduction about physiotherapy in the primary healthcare in Sweden. So can I not? Doesn't seem like I can. Oh, there we go. So healthcare in Sweden is governed by a national agency. So Socialstyrelsen is the National Agency for Health and Welfare. And they are there to ensure that healthcare is safe for patients, that it's equal. So you shouldn't receive different care depending on where in the country you live. They're also there to ensure that the healthcare we provide is of high quality. And they do provide national guidelines. The national guidelines have been founded by statistics and research. And those guidelines are there to help in decision making on methods and treatment that should be prioritized in healthcare in Sweden. So healthcare in Sweden is divided into 21 regions and 290 counties. So the regions, they are responsible to provide healthcare in hospitals and in primary healthcare. And the counties are then, they provide the communal healthcare, which is in Sweden mainly is aged care. It's if you have disabilities, support care after hospitals, admissions, and then also the school health. So the primary healthcare system is an open, it's like kind of the foundation of the Swedish healthcare. So it's an open access without limitations. So you can't say no to anyone. You have to, the patient that contacts you, you have to look after. So it has a duty to provide basic medical care, caregiving, prevention, and rehabilitation for patients that do not require specialized medical treatments, so from the hospitals. The regions also, they have to provide healthcare according to the healthcare choice model. And this choice model is that people can choose where they want to go. So you have different clinics and the patient will list them at a certain clinic, and that's the clinic has to look after them. All healthcare providers that match the criteria in a region, they can establish themselves, and then they are then compensated by each region. And different regions will have different compensation systems. And in general, you can see doctors, nurses, psychologists, counselors, occupational therapists, physiotherapists, midwives, speech pathologists, and dietitians in the primary healthcare setting. It is a little bit complex because how you're compensated varies in each region. So some regions offer fixed compensations for the member patients or the patients that have listed themselves at your clinic. Some compensate you for your ability to care for your patients. So your patients don't have to seek care anywhere else. So if you don't manage to match, if you can't look after your patient and they go somewhere else, you will actually be negatively compensated. And some regions will compensate yourself per appointment or treatment you do. Some will have goal-oriented compensation. So if you can achieve certain goals, it can be specific diagnosis compensation, and it can also be sometimes be socioeconomy. So depending if you have in your region with maybe lower socioeconomical conditions, you might be compensated a little bit more because it might, in general, that's a bit harder. Then we also have the enhanced healthcare guarantee. So if you contact your clinic, they need to call you back within a day. They also need to provide a first assessment for a new condition, not an already ongoing condition that you already have medical treatment for, but a new condition within 3 days. and it needs to be done by a registered health professional. So the clinic in general can almost choose who should do the first assessment. And they're trying to do that by who is the most suitable for the condition the patient is presenting with. So it is pretty much consensus in Sweden now that physiotherapists should be the first assessor of musculoskeletal issues. Some other problems too, obviously, but that's, if you have come in with a sore shoulder or knee, you should see a physio first, not a doctor. Then we have something called a high cost protection for the patients. So they will not pay more than Swedish crowns, which is around 1,150 to 1,200. It differs a little bit depending on regions, per 12-month period. So that's about 110 to 115 euros. And then we have free healthcare for elderly. So if you're over 85, and then for children and youth up to 20 years of age is free in all regions. When you pay the money to go there, it's actually not paid to the clinic. It goes to the region, and the region will then compensate the clinics for what you have done. So now I will move on to what physiotherapists do. So you can have different types of physiotherapists in the primary healthcare setting. You can have the fully private ones, and they are not actually really linked to this care choice model. So they will have to have their own fees. For them, you will actually pay a fee, but then you choose to go there. It's a lot more expensive. Then you can have a private or self-employed one that are linked to this regional system. You can have people employed just at the clinic with only physios, or you can have some that are working with other rehab professionals. And then you can also have everyone. You have like the nurses and doctors, physios, occupational therapists, psychologists, everything. So how do you access physiotherapy? So you don't need a referral. You haven't needed that for a long time. So people can just call up or come and book an appointment for a physio. The clinics that are linked to the region's choice model, they have to provide booking. So people have to be able to come in person and book. They can be call or they can do it online. Then we have to feed back to them within 1 day. And like I said before, we have to provide a first assessment by a doctor, a nurse, a physio, and occupational within 3 days. It becomes a bit complex because there are some regional differences. In some regions, the primary healthcare will also be doing a bit of home care and aged care, while in others, that's more the communal care. Then also the referability will vary. So in some regions, you can do X-ray referrals, and you can also refer to an orthopedic surgeon. In general, like actually, if you look back at the national healthcare, we should be able to do it everywhere, but it is up to the employer to make sure that you can do it. And sometimes the orthopedic surgeons won't accept a referral from a physio, but this is something we are trying to push in Sweden, so that will become a consensus. So the patients we see in primary healthcare, that's obviously the big group. The traditional group has been the MuSK problems. But it's also a lot of neurological conditions. So, for example, a stroke might first have inpatient care in a hospital, but then they will often end up in primary healthcare setting later on. We have lots of cardiovascular conditions that we see in metabolic conditions, diabetes, pulmonary, like COPD. Mental health is a big group in Sweden. Depression and stress, it's a big group and it's growing. Aged care, like fall prevention that we heard about from Constance, and then also big preventive care. We're trying to reduce the impact and reduce the development of chronic conditions. Also a big group that is growing. How do we work in the primary healthcare setting in Sweden? So we do lots of one-on-one treatment. We do groups. Balance groups are common. You have to actually, if you're linked to the regions, you have to have an osteoarthritis group. We have a big national system where we report that people go to the osteo group, and then the outcome before the group and the outcome after, how many needed a surgery. So we have a big statistics on this group. There could be stress, sleep groups, lots of different things. And then we have teamwork with other health professionals, particularly around the chronic patients. Digital, I guess everyone during the pandemic, this has exploded. So we do one-on-one, we do groups there, we do patient education. That could be they could be pre-recorded patient education, or it could be direct, like we're doing now. We can also do teamwork digitally now. So we do when people, for example, get discharged from hospital, we might have a planning session what's going to happen. So we do that now on Teams or Skype, different things. We can do telephone appointments and home visits. And then all these things might vary slightly in the region, but in general, we will all do these things. Yeah, and that's me actually. I'm done.
Oh, thank you. Thank you, Rebecca, for the insight in this the system, how it works in Sweden. I think we will come back to the questions in the discussion part. I think then we can combine all the different views. But I also have some questions already. But thank you so much. We will continue, and we will go next to our the speaker, Chris Mercer. He's a consultant physiotherapist working in an NHS. He's also the National Clinical Lead of Primary and Community Care for the Best MSK Health Program and co-chair of the National Consultant Group for Physiotherapists. Chris, I give the floor to you.
That's great, thanks, and thank you for the invite, and good evening all, and thanks for turning up. It's great to see everyone, and so many countries represented, so hi everyone. Yeah, I'm Chris Mercer, I'm a consultant musculoskeletal physio. So I'm going to talk about the first contact physio roles in the UK, and these are different to direct access roles, so I'll talk a little bit about how they're different as I go through the presentation. Liva, can you see my screen okay?
Yes, it's very good.
Okay, thanks. Okay, so the first contact practitioners are musculoskeletal roles based in primary care, and they're designed to support the primary care workforce in the UK. So they sit alongside GPs within GP practices. So they're not there to do physiotherapy treatment. It's a triage and referral service. So this is about having highly skilled physiotherapy, musculoskeletal physiotherapists at the front end of the service, so that patients get directed to the right place. So these clinicians are there with additional skills. So they have skills to prescribe medication for musculoskeletal conditions. They have injection skills. They can request imaging and request blood tests. So they're doing all of that diagnostic workup at the front end of the patient pathway. So the document shown here is a national document that's been developed, which is a roadmap to practice for first contact practitioners. So the requirements for the first contact practitioner is that they should be at least 5 years qualified, and 3 years of that to be in a specialist area. So within musculoskeletal, so 5 years qualified overall. And there are two routes into becoming a first contact practitioner. So just before I talk about those two routes, in the UK we have 4 pillars of advanced practice. So a first contact practitioner is working at master's level within the clinical aspect. This first one here on the left is working in that first aspect of clinical of the 4 pillars. So in clinical practice, but may want to go on to develop master's level skills in these other areas. So the learning, the leadership, and the evidence and research, and that might be part of their career trajectory. But initially, the first contact role is around developing clinical expertise in musculoskeletal. So it's part of a pathway. So the FCP sits within this Venn diagram here in the middle. So FCP is here. So the person has become registered. They've done some additional training, but they're on a route, on a trajectory to advanced practice roles and consultant level practice. So the advanced level roles are slightly different because in those roles, somebody needs to be able to demonstrate that they are working at master's level in all 4 of those pillars that I've just shown. For FCP, it's within this clinical aspect. So the training needed to work in primary care is very specific to the primary care role, and it's tailored towards supporting MSK at the front door. So it's based around some basic kind of generic knowledge, skills and attributes, and then divided into 3 different stages. So those stages look a bit like this. So in stage 1, first contact practitioners are required to have done this training before they go into primary care. So stage 1 is comprised of doing an either they can do a university-based course that's tailored towards first contact practitioner, or they can do it with a portfolio route, and they need to have done these modules before they start work in primary care. For stage 2, that's done whilst they're on the job in primary care, and that's about learning to work in primary care alongside all those other healthcare professionals that Constance and Rebecca have talked about. And that's about understanding where they sit in the patient pathway and how they're going to receive the patients and manage their kind of diagnostic workup. So really these roles are about replacing the GPs, replacing doctors at the front end and putting physiotherapists in those expert roles. They're not supposed to do any treatment in primary care. They will refer on to physios for treatment to our direct access physiotherapists within the community and primary care settings, but these are purely diagnostic roles. And given that somewhere between 1 in 5 and 1 in 3 GP consultations in the UK are related to MSK problems, that's why these roles are there. They're there to support that. And there's a stage 3 that goes on here, and that's the role, moving into advanced practice role and development. So this is what the paperwork looks like, and these are based on 2 different documents. Over here on the right hand side, these competencies are matched against the IFOMT competencies, which is the Musculoskeletal World Physio Group. They have a set of standards and competencies, so it's mapped against that framework. And down the left-hand side here is a UK-based musculoskeletal competency framework that it's mapped against. So these people have to demonstrate these high levels of skills before going into role. And these are across different domains. So this one, for example, is around assessment, investigation and diagnosis. And so they need to be able to demonstrate this before they start. Sign that off, and then for stage 2, when they're in primary care roles, they have more specific higher level requirements and competency to sign off, and a lot of that is around being watched. It's around case discussions with the GPs and various other competencies that are signed off here, and that's part of an ongoing clinical governance arrangement. So you can see that it's a journey. The FCP role is a journey. You don't have to carry on along this line. You can stop at FCP. You can stop anywhere along this line. I've chosen to stop at this end because I'm old and I've been around a long time. but I've also done this role here, this FCP role in the middle. I've been doing that for a year. I've just actually finished doing it. But even after 30 years of being qualified and 25 years as a MSK physio, this is a really challenging role and very different to the direct access physio that I've been doing for the last 25 years. Very, very different, very different patient group, really. A lot of undifferentiated diagnoses, lots of diagnostic workup, lots of things that weren't musculoskeletal. So the kind of broader knowledge of masqueraders and things was much more important. So that's where we're at in the UK. It's a program that's been rolled out over the last sort of 2 to 5 years, and it's not going anywhere soon. It's our major problem is recruiting the workforce. We've used up a lot of our experts within the system to take on these roles, and that's our challenge at the moment, is making sure we've got enough workforce to fulfill these roles as well as the usual physiotherapy roles. We've lost a lot of very experienced physiotherapists into these FCP roles, which is having an impact on physiotherapy in general and our ability to deliver. But that's the downside. But there's lots of positives. This is a great advocate for physiotherapy. This is putting physiotherapy expertise at the front of the pathway. So I think there's a lot to be said for these roles, and happily it comes under the work stream I'm leading for NHS England at the moment. So it's a really good and exciting time to be involved. So that's me. Thank you very much. Thanks for your attention, and I look forward to the other talks. Thanks all.
Thank you, Chris. Thank you so much for your presentation. We are now moving to the third speaker in this section. So I now give the floor to Firas Mourad. Firas is a special consultant in polyambulatorio physio power and lecturer in the Lunex University and Università di Roma Tor Vergata e La Sapienza, and will present the Italian perspective of direct access and self-referral to physiotherapy in primary care. Firas, please proceed.
Yeah, good afternoon, everybody. Let's share the screen. Microsoft PowerPoint. Can you see my full screen? Is it
Yes.
a full screen slide or?
Full screen, it's fine.
Okay, great. Okay. Good afternoon, everybody. Thank you for the invitation. I will have this short chat to explain the Italian perspective on the direct access and the self-referral to physiotherapy in primary care. So I will anticipate a little bit the discussion, as this slide, is just a kind of summarize of the best evidence that we have to support the direct access to physiotherapy. You will find a lot of references here. There are a lot of recent European strategic experiences that reported a lot of benefits and advantages for both the direct access to physiotherapy or the direct triaging to physiotherapy in primary care. And all this result obviously support the clinical, political, and economic solution for the ongoing citizen request, demands, and the system needs as well. Especially in a period of time where we got a lot of trouble, and we just moved through a crisis of the health system because the overload of the hospitals and the shortage of medical doctors, especially because of the COVID-19 pandemic. We have a very recent study from UK, from Sweden, for example, that show that first contact or direct access to physiotherapy has the same effectiveness and is safe as the physician-led pathway. However, it shows greater benefit for indirect outcomes, such as reduction of medication intake, a reduction in loss of work days, reduction in number of imaging investigation, reduction of hospitalization rate, reduction in waiting time, and obviously all of this, it reflects also a reduction in the economic burden for the health system. Obviously, as I'm the vice president of the Italian musculoskeletal group, I will refer mainly for patients that has musculoskeletal disorder. And another important aspect to underline here is that we know from 10 years that the baseline knowledge of physios are equivalent to the medical doctor one, the general practitioner one, on the domain of the musculoskeletal disorder management. And we know also that the specialized physiotherapy, so the one that got a specialization in musculoskeletal physiotherapy, for example, iPhone programs, has a better knowledge and is almost close to the one of the orthopedic physician. So this things makes interesting this observation, because we know that, for example, musculoskeletal physiotherapy now follow certain international standards for all those masters that are based on the iPhone educational standards. And then it makes this observation, that this study, this survey that was done in US, generalizable also for other countries. In Italy, for example, we got recently the law number 43 of 2006 that define the specialization also for healthcare professional, and the specialization can be gained through university master's programs, and then having a musculoskeletal specialization and then a master programs. I mean, it's a kind of guarantee of knowledge as well, compared to the general practitioner one. So what is happening in Italy? Historically, physiotherapists were considered as an ancillary profession to physician until the '94, where it was defined for the first time the professional profile of physiotherapy, where it was clearly stated that physiotherapy is the healthcare professional who provide prevention care and rehabilitative intervention in autonomy, or collaborating with other healthcare professionals. And however, this concept of a subalternity of physiotherapist to physician, it's still present in certain fields. There are still some medical doctors that still behave and believe that physio are still an auxiliary profession. However, this concept is not longer plausible or realistic after this two recent law, the law number 3 of 2018, where finally all healthcare professionals got an ordinal an order, and the law 24 of 2017, where it completely changed the matter of responsibility, the penal responsibility for health professional, that now falls on each individual professional who operates according to the best practice and international guidelines. Based on this short introduction, we recently published this communication providing justification for starting to recognize and to regulate the direct access to physiotherapy in Italy. In fact, nowadays in Italy, the direct access is permitted, but is not fully regulated. So patient can get access directly to physiotherapy because, it's their right, it's their free choice to choose, to decide which pathway of care to take when they are seeking help for any health problem. But as this direct access in physiotherapy is mainly fully private practice, all the expenses, it's out of the pocket from the patient, so it's directly paid by the patient. Otherwise, if we talk about the public health system, is the majority, most of the time, the physiotherapy intervention, it happens only after a diagnosis and a prescription from a physician. So there is not a real direct access, except few exceptions. The main problem here, and it's another argument between physio and medical doctor, is between the term diagnosis that yes, medical diagnosis possess a legal and political implication, and obviously provide benefit for the access for free welfare in Italy. But medical diagnosis, it's different from what we call in Italy functional diagnosis for physiotherapy, where we focus more on the limitation in the performance of activity or restriction in participation because the disease or the pathology. This is important because we know that 90% of musculoskeletal disorder, probably more, has a non-specific musculoskeletal condition, so they are not inside any medical or serious pathology that require a medical consultation or diagnosis for that. And our commentary was directed for a call for recognizing and regulate the direct access in primary care for physiotherapy as as the appropriate case manager for musculoskeletal disorder, obviously the mild one, not obviously the specific pathology related to musculoskeletal disorder. And then this change should represent an opportunity not for the category, but mainly for improving the quality of care for the healthcare system. And we tried also, with this funny infographic to summarize the benefits and the pathway that rely on the direct access in physiotherapy, where the patient got his first consultation by a physio. And the interesting things from our review of the literature is that physiotherapists show also a very high and accurate rate for referral for specialistic medical doctor visit, for example, to orthopedic surgeon. And obviously this reinforce again the concept that physiotherapist has the skill and are capable to also triage those patients that are outside the scope of practice. So yeah, we know that this is just something a matter. In Italy, as you saw before, the profession. It's very young. It's only a matter of time. Things is changing very quickly in Italy, and direct access to physiotherapy in a private setting, it's something that comes very common. And the most important thing is obviously maintaining communication, especially with the medical professionals, and to avoid, to try to stimulate this ontological change, this ontological shift that should also challenge the way medicine and healthcare are organized, managed, and financed. And obviously, this is because we need to provide, strength to this dualism that sometimes we have in Italy. So this dualism between the medical profession and physiotherapists, and then avoid isolated silos healthcare system and look at focus more on the benefits that direct access for patients with musculoskeletal condition can the benefits that this kind of pathway can provide to the singular citizen. Thank you so much.
Thank you, Firas, for your presentation and the insights in how the primary healthcare works in Italy. So with your presentation, we are finished with the presenting part, and we can now move to discussion part. So I invite all the speakers to come in, and we invite for the participants, we invite you to write the questions in a Q&A, and I will now read the questions that have already came in. And Rebecca, I will start with the questions that has been addressed to you. In Sweden, has there been any negative side effects after introducing direct access?
I was just thinking, what do you mean about side effects to the patients or to practitioners? If the person would like to kind of evolve the question, maybe.
Yes,
Or
maybe I think it's
in general, I might say that it probably hasn't, because private previously it was more like in Italy, it was mainly private practitioners that could provide direct access. So in general, actually, I think it's better because now it's a part of the big system, the public system too. So which means that any patient can access this. Beforehand, it was only the people with more money that could access physios directly. But like we've been saying, if you look at in general, outcomes have become better because more people can access the care they need. And also in many cases, we are actually better assessors than doctors. So they're getting both, they're getting treated and they're getting assessed by the most suitable professional. So it's, yeah.
Thank you. Then there is
may I
yes?
add one thing?
Yeah.
Since 2014, it was published 7 systematic review on this, mainly focused on this topic, effectiveness and safety of the direct access to physiotherapy compared to the physician-led pathway. And I mean, the result for both safety, so having adverse events for physio because because obviously they did not recognize pathologies outside the scope of practice, or the effectiveness in terms of pain. There is not that much difference between the two pathways, so the physician-led one and the physiotherapy one. So the concern is not about the safety, and we know also that physio are so good, and this is, for example, is a study from England. They Donny 2019. They got a great experiences in Wales, if I'm not wrong. They published a very interesting paper, and they saw that the appropriateness of referral of physiotherapists as first contact practitioner was extremely accurate. So it's not a concern about the safety, but I mean, the other important things that we know today, that we provide more benefit, especially for cost and secondary outcome compared to medical doctors, mainly general practitioner. And the other things that we know that we can remove at least 30% of their caseload, knowing that probably we are better prepared than them on the musculoskeletal field.
Thank you, Chris. I see that you.
Yeah, it was just to follow on from that point, really, that Firas made, just looking at the impact of first contact practitioners, specifically in terms of their onward referral rates, were at least 30% less than the medical colleagues. Their prescription rates were about 50% less than the medical colleagues, and they played a big role in deprescribing a lot of the medication that patients were on. So those first contact practitioners who are independent prescribers, their main role has been in deprescribing medication for people with musculoskeletal disorders. So there's an impact there for the patient, but an impact also in terms of kind of the health system and funds and efficiency, because they're requesting less imaging. They're taking people off drugs that they don't need to be on.
Thank you. Thank you for that. I will ask Rebecca one more question to you. Could you tell us more for the salary of the physiotherapists in Sweden?
Oh yes, so I was trying to have a look, and I think like when you are have just graduated is I think it's about 2,600 euros a month, and unfortunately we have a pretty poor salary like from there on. Like later on, I think it's if you maybe are in like 35 years of age, you said the median income was about 3,200 euros, and about 10 years later it's not that much better. So we are working on that. That's something actually our union and professional board is pushing quite a lot. So we're trying to get our salaries to increase, and it is slowly starting to change, which is good, but it's not the best.
Okay, thank you.
That has improved since we had started getting direct access physio, because they did see the value of us. They're starting to, that's kind of pushing it. So I should add that.
Mm-hmm. Mm-hmm. Okay, there are, I think, few more questions to you, but I will now ask a question to Chris. Lefteris is asking, who is responsible for the education development? Could you tell us more about the exams or the portfolio of the?
Yep. Yeah, for sure. So there's an organisation in the UK called Health Education England. So as the name implies, they're responsible for education of the workforce, and they're linked in with NHS England, which is a national body. So the university courses are run individually by the universities against a set programme set by Health Education England. It has to meet their criteria, but the portfolio route is run through a system with Health Education England. There's a place called the Centre for Advancing Practice, where people submit their portfolios of evidence. So it's done as a national thing, but the work on the ground is done by a team of supervisors. So at the moment, I think there are around 900 supervisors in the UK who supervise first contact practitioners individually. So they will sign off various bits of work.
Mm-hmm. Okay, nice. And could you, Chris, maybe tell a bit more, where is the first contact practitioners placed in NHS?
Yeah, they're all NHS roles at the moment. So some are provided by people working from private practice, but they will be working in an NHS role. So they are all NHS roles. There are no independent sector or private sector roles, but we are using workforce from the NHS and from the private sector.
I see that there is a question to Firas. How Alina says that she's interested in exploring the ontological question you raised. How can we overcome the resistance to the development of the profession among our colleagues?
I mean, this is a good question. I mean, it depends from country to country, really, because again, I mean, I can speak about what is happening in Italy, and I mean, especially after the pandemic, the COVID-19 pandemic. I mean, the private services. I mean, they are increasing a lot. The number of patients. I mean, the number of patients that seek help from the fully private services, it's increasing because, I mean, the public health system, I mean, it has a lot of waiting lists. So, and physio here in Italy, the profession is, I mean, is like everywhere in the worldwide. I mean, it's increasing competences and knowledge hugely, rapidly, and it's impacting a lot also the profession and its identity and how other professionals see us within the healthcare system. So I'm pretty sure that in Italy something will be changed, because also, I mean, all the new generation of medical doctors, now understood that, I mean, we talk and we work at the same level within the interdisciplinary team. It's just a time of a matter of time, and obviously it's most important thing. It's rising constantly the level of the profession, providing, I mean, education. There is no other choices.
Mm. Yeah, nice. Thank you. Constance, there is a question to you. The Stefan is asking, how can Europe region World Physiotherapy support members to argue politically towards physiotherapy in primary health?
Yeah, thank you for the question. Hello, Stefan. Long time no seen, as we say. Well, I think we should differ between the members of the European region and the members of the member organization. To the members of the region, there is a lot of discussion going on in the working groups, and we do this within our working group also, that we try to advocate for physiotherapists in primary health care. And yeah, it's the support is to encourage everybody to get engaged and to work on national level also, and to promote the physiotherapist role and to use the info material and the resources that we have. And to the physiotherapists working in the field, to the members of our member organizations, I think it's very, very helpful always to have in mind that the strongest advocates for physiotherapy probably are our patients, and to encourage them to spread the word, what we do, how we are able to help them, that they're happy with what we do, and to spread the word within their community, their relatives, their general practitioners also. And if they know somebody in the political field, also to talk to them. And they surely can use the material that the national organization provides in the country language. And they also can get in touch with the professional organization, because we are always happy to get in contact with our members, and we love if they are active and approach us, and so that we can support them best as we can.
Thank you, Constance. I was thinking, Tim, maybe you want to add something?
No, thank you. I think that Constance already answered, and I answered in writing. So thank you for the opportunity.
Okay, thank you very much. Then I have a question to each one of you. It's about how many first contact physiotherapists are there in your country? Rebecca, maybe we can start with you.
I'm not actually sure. I can't remember now. I should know, but we are quite a few, because we don't actually have to be specialized like in the UK. So yeah, I have to get back to you on that one. But it's quite a few. Okay, it's very common.
Okay. Yes, you can come back to with the answer, Chris. I know that.
Yep. So direct access physiotherapy is every musculoskeletal physiotherapist in the UK, which is about 22,000. For first contact practitioners, which is the kind of GP role that I was talking about, there are around 1,500, maybe a bit more, about 1,800 at the moment, something around that, with a view to that being 2,500 by the end of next year.
Firas, could you tell more about Italy?
I don't really know. I mean, they are never been surveyed before, so we don't have any official numbers. Also, because again, there is not a real regulation on that, and then it's very difficult. I mean, the local physio association never run any survey on that, but I mean, this is a good idea for run one. To tell them to run one. for knowing this interesting information.
Okay, Constance, I know that you have how many physiotherapists you have in a primary healthcare? Oh, sorry, we don't hear you.
Yeah. Well, actually, we don't know by now because primary healthcare is very young in Austria. And we tried to make a survey, or we're working on a survey on that a couple of months ago, and we had some responses, but it weren't that many. So primary healthcare is still, as we say in Austria, in the Kinderschuss, in the children's shoes, we are in small steps, but we are trying to establish a network on this with colleagues working in primary healthcare and who are interested in working, so to connect them and to grow.
Okay. As much as I would like to continue the discussion, there are more questions, but I'm looking at the time schedule, and I will ask this last question. In Belgium, there are more incoming non-medical professionals involved in primary healthcare, like gymnastic teachers and coaches who teach movement on a prescription. In other countries, is the situation the same? You can really jump in with.
Yes, for the UK, and we're desperate for workforce, as I said in my presentation. So we have osteopaths, some chiropractors, not many chiropractors, a lot of osteopaths, but also looking at wider roles like health coaches and social prescribers, who are people who help people with mental health issues and navigating through the system. So it's a lot broader primary care workforce, which is great.
Chris, can I please do a follow-up question on that? You actually see that as a good thing for your system, because where I understand that for Belgium, this is actually kind of a threat to the healthcare system. So can you please elaborate on that?
Yeah, for sure, Tim. And I think our challenge is we don't have enough physios to do those roles. So yeah, we've had osteopaths working in our physio departments for a long time and working in our single points of access. So we've got very good kind of professional relationships with osteopaths. So that's been a natural progression for them to work in first contact practitioner roles. But the broader healthcare and some of the preventative and the rehab work, a lot of that we're linking up with local gyms and strength and conditioning professionals and sport and exercise medicine professionals to try and just boost the workforce, really. So it's not seen as a threat so much here, but we're working closely with those bodies. But I take your point. It's just where we're at in the UK, I think. Yeah.
Thank you. Are there any other reflection about this question? Then I give a word to Aderito, I think, and.
Okay, we can have the perspective from Firas and Constance about this question. How is the reality in Italy about the other professionals coming to primary healthcare?
I mean, there is not a question for Italy, because osteopaths, they are still not a fully recognized healthcare professional. But yeah, so I mean, we cannot count them. What is the other profession?
Well, if there are, for instance, sport professionals in the area of sport, if they are working or if they are trying to get in primary healthcare in Italy, if this is also a reality. In Belgium, this is something that is happening. In Portugal, it's also a reality. It's happening. So
yeah, but what does it mean exactly? I mean, they treat patient, or they just got?
No, they are they are being inserted in the primary healthcare to work with patients related to physical activity prescription, for instance.
No, in Italy is not that much common. No, still not.
And you, Constance, what about the reality in Austria?
Yes, it's clear that some other professions try to, let's say, fish in our waters, and it's a reality that people who call themselves osteopaths try to get in, also sport therapists and so on and so on. And I think that what a really big problem which is arising is the term of the social prescribing, because social prescribing is a very good thing when it's used correctly, but it's misused sometimes to say, well, it's a prescription. And so now I'm allowed to work with a patient even if I'm not a health professional. And this clearly needs clarification in Austria, maybe in other countries as well, but.
Thank you. Well, actually, that's the point. But well, I feel that this will be a discussion for another webinar, because I think we will have a lot of things to discuss, and we are right on schedule. So
can I add just one last thing? Please. I mean, because I talk on the slide about the private and the public health system. I mean, if we talk about the public health system, if you are not a healthcare professional, you cannot work in primary care. But if we talk about the private system, so if the patient is paying out of his pocket, I mean, he's free to choose where to go. So it can happen, obviously, that he will self-refer himself to other profession, but I mean, it's not that common still.
Okay, Firas, thank you. Well, thank you all for your presence. We hope you found this webinar as interesting as we did. Many interesting insights about the role of physiotherapy in primary healthcare were provided, and the Advocacy and EU Matters Working Group will definitely consider them in future advocacy initiatives. I will now give the floor to Tim for the closing remarks.
Thank you, Adelito, for this. Okay, so I hope you all enjoyed this first webinar of the Advocacy and EU Matters Working Group of the European region. I would like to thank you all for participating. Thank you, Rebecca, Chris, and Firas. Thank you to the members of the team that engaged and organized this session. And a special thanks to Aitor and Miguel for the logistics. Our gratitude goes to the Latvian Physiotherapy Association for letting us use their Zoom account. And I'm really looking forward to seeing you all in a following session. So take care and good night, everybody. Bye-bye.